Okay, well, we're going to move on to case number 2. And this is a 20-year-old white male, works in programming for a tech company, and when not programming, likes to spend free time as a gamer. So there's a little visual demand there.
Yeah, he obviously lives at home, and he's
And surprise, complains of fluctuating vision after several hours and needs to take frequent breaks and doses with lubricants. So let's take a look at.
Let's call him Brad.
Call him Brad.
Yeah,
patient Brad.
Yeah, it's Brad.
Okay. Let's call him patient Brad. And so let's take a look at Brad's Meibography. Do you use Meibography in your practice?
We do. I don't use it as much as I used to. And I think part of the reason why, Doug, is that, we're all like patient flow is always kind of a little bit of an issue. So to your point, you do a speed test or you do a questionnaire. And even in your practice, if you don't even do those, if your staff, to me, I kind of feel like you have to empower them. Like if they're doing a topography, if they're doing a pentacam, if they're doing an autorefractor, and they can see that the Myers or the quality of that isn't great, then that to me should be a trigger that maybe they should do more testing. So doing more testing. The challenge we had, especially with the Meibography, was the dexterity of it or getting it done. There's a great device called the Myverter, which you can use to flip the upper lid. It's developed from a Canadian optometrist up there in Toronto. Look that up, Meiverto, Myverter. So to answer your question, I do, but not as much as I used to. And I'll tell you one more thing I know, is that I don't necessarily use it as a, to differentiate my diagnosis or my treatment. I'll use it more as an educational tool.
Yeah, 100% agree with you. And patient flow is the most difficult aspect of integrating any type of technology into a practice.
Yeah.
And what we did within our practice is the speed questionnaire, it's above 6, all the point of care tests, which I include Meibography, and we just automatically do it. When it becomes so automatic and all the technicians get up to speed with it, it seems to flow pretty well on that. So I still use it, and 100%. It isn't diagnostic for me near as much, because when we're looking at Meibomian glands like we're looking at here, there's structure of the glands and there's function of the glands.
100%, yeah.
And when we talk about structure of the glands, yeah, that's important, that's a direction, but that doesn't tell us anything. We could have a full, nice set of Meibomian glands, and when we look at the function, what's the function? The function is what you said earlier, pressing on those Meibomian glands.
Right. I think the other thing too is that in this day and age, we're well aware of the fact that we blink 1/3 of the amount of time that we normally do. And here, our patient's younger. He's works on a computer. When he's not working on a computer, he's playing on a computer. I mean, look at him. Look how young he is.
I know.
Right?
Young man.
That is one svelte, young-looking guy.
Yes, it is. That 28-year-old is.
He's lived hard. But look, you can see a little bit of some neovascularization on there. And Doug, you love to talk about this. What do you not see?
Yeah. What I don't see is nice clear oil coming out of the glands. You can see actually on some of the inspensation where you're not seeing anything wick across the lid margin and get into the tear film on this. And there's some other points here where
look at the neo. Look at the fine blood vessels that are just coursing through there in the
injection. Lot of inflammation on that on that eyelid margin that we're looking at on that. So. Yeah, and I think that's so simple. All you need is you're doing your slit lamp exam, you take a Q-tip or your fingertip and you start pressing on the Meibomian glands. There's other tools that you can use. Like I said, I tend to be a minimalist, so I will have just something real easy just to press on it and don't go to
Now, do you press on all 15 or do you pick the central 5?
Yeah,
you use
I'm
it as
central.
an example?
Yeah, I do the central, and I just really want to see, I want to get a good look. So this would be a good example of just, trying to press on those Meibomian glands and what kind of response we're going to get.
See, it's so interesting too, though, is that it's like there's other telltale signs for me that I would just look at and just kind of feel like we're not heading the right direction, is the fact that you have a 28-year-old who's a gamer.
See how inspensated this is.
Oh, yeah, it's terrible. I mean, those are capped, and look at all the neo again. Yeah. I mean, I'm already making my diagnosis before I'm doing anything, So, yeah. The other thing too, in that last patient, did you see the pores on their nose? Because once you see it, you can't unsee it.
I know.
Yeah.
I never saw it before, but
Now
you
you
pointed
can't.
it out.
And
now-
that implies to me rosacea. That implies to me, you know, that these glands are going to be clogged or capped. You know what else is very interesting too, Doug, is that when you're pushing on that, you had said this to me once, is that when you blink, that should be something comfortable. And then when we're pushing on those and blinking, all that crap's on there, it's not comfortable.
Right, right, exactly.
It's the
because
antithesis of what it should be.
It absolutely is, because that saponification is taking place in the meibum, and when you get that into the eye, it's just not a comfortable, comfortable type of thing.
I'm going to tell this patient we need to get those glands secreting better. So something like a moist heat mask at home, you know, and I like moist heat. I mean, I'm all about the moist heat. A moist heat mask at home to try to kind of stimulate the production of those. And I always say something like, you know, but we have a procedure that we can do that heats up these glands, that we can then do like a manual expression of the glands to help almost, and I try to draw analogies to things kind of like, you know, a deep clean or taking your car and getting a detail, you know, and then you just wait until it gets dirty again, is to get us back to like, you know, that null point. And I'm usually apt to say, look, that's something we can do, but we may not do it at this moment. The other aspect of it is that I'm always concerned, and you saw in those lids, you saw Brad, the 28-year-old gamer who looks like he's about 60. I would absolutely be concerned about inflammation. So that obstruction and that inflammatory. So I'm putting them on perfluorohexyloctane. I'm absolutely going to put them on an anti-inflammatory. And then I'm also absolutely in my mind thinking long-term, something like cyclosporin or lifitegrast, you know, to basically try to keep things at bay. Because he's young, so I don't want to do too much, but I also don't want it to progress to a point where it's terrible. What are you doing?
Well, I'm going to tell you what my typical dialogue would be for this patient that we saw. With
Pretend I'm the 28-year-old.
With the ocular
Yo, what up?
rosacea.
What up, Doc G?
What I would tell you is that I've seen, you know, your condition. You have an evaporative condition. I would definitely go and say we're gonna break your treatment into several parts, and the first part is going to be taking care of the acute nature of what you have, which you have some inflammation, you have a high evaporation. We're going to take it, but we have to deal with the damage that has been done over long-term abuse and obstruction of these oil glands. And I will talk about intense pulse light treatment, and that we have this available, and how we borrowed it from dermatology a number of years ago, followed by a thermal expression. And thermal expression is heating those glands up and gently squeezing those glands, kind of like you're squeezing the bottom of a toothpaste tube that has something clogged in the opening. But we have to take care of the long-term effect of the damage that has already been done, but we're going to deal with the acute nature of the condition right now to get you feeling more comfortable, but we're going to have to repair the damage. So very similar to what you saying, just say we're going to break it into a couple segments.
You know what, the other thing too, that is you don't have to have every piece of equipment in your practice. I mean, intra-optometric referrals, I think, is just a phenomenal opportunity amongst clinicians, or even if you share equipment. There's a manual intelligent heat and manual expression device, which is handheld, which uses smart lids and a smart hub that different clinicians could share. I mean, an IPL, we don't have IPL. So I know who does in the Valley, and I will refer patients there.
And to that point, I get referrals all the time for doctors that are managing dry, but they look at this this inflammatory condition of the lids, the ocular rosacea, and the obstruction. They'll refer over for IPL as well as thermal. But I would say, Marc, right now we have so many choices in thermal expression that there's not really a reason not to incorporate it in. Right. I mean, it reimburses well. Easy, not a large capital investment now. There's a lot of different devices you can use right now.
Are you saying that it's insurance, that you can bill for insurance?
No, and that's the beauty of it.
Yeah.
It's cash.
Yeah.
But I think that opportunity is out there, that there's no reason that practices don't start to adopt that, just simply because of, the numbers. 86% of the dry eye patients have a Meibomian gland component to them.
Evaporative. How do you talk to patients about cost? Because I remember once you told me something that you say to patients, and I've adopted it, where you basically say your out-of-pocket expense.
I do. Yeah.
I think we get hung up as ODs in kind of like, all right, this is how much. And I feel our MD and DO colleagues are more of like, well, this is how much it's going to cost. And they're unabashed about it. And I love the notion of just saying your out-of-pocket expense is going to be whatever it is.
Yeah, you definitely don't open up with, and I never say, oh, your insurance doesn't cover this. It just always is your out-of-pocket expense, because that's all patients really care about. It doesn't matter whether it was insured and it was $10,000 and now their out-of-pocket expense is going to be $600 or $700.
Right.
It doesn't matter. What they want to know is, what are they writing the check for?
Right. And I know you probably aren't too keen on this, but I go the opposite way. I feel when something is covered by insurance, then I feel I have a lot more access to it, and it opens up a little bit more universality to it. There's SightSciences, who one of the companies that we work with. They have a 2-year clinical study that they've just reported their 6-month data and their 1-year data. It's called the Harrow study. And within the study, what they are doing is trying to determine whether or not a single procedure of a lid expression, intelligent heat lid expression, compared to using cyclosporin. And at the time, the only branded name prescription out there was 0.05% cyclosporin, and in their initial 6-month data so far, they've demonstrated that it is superior with Meibomian gland secretion scores, but it's non-inferior, meaning it's the same with both symptoms and with Schirmer scores. So what's nice about that is they want to be able to go to insurance companies and basically say, look, you're paying for cyclosporin and you're paying for lifitegrast, you're paying for the other things. Why are you not also covering a procedure that has the potential of doing almost the same thing? And the nice thing about that, I feel, for us as clinicians, is when you do something in your practice, then that adherence is 100% because you're doing it. You're not expecting them to do it somewhere else. So keep an eye out on the Sahara study. I think it's they're going to start. I think their 1-year data is coming out soon too.
The dialogue that you have with the patient is absolutely the most critical aspect to be working toward adherence and to try to get some buy-in by the patient. And that's why I always refer to it as there's damage that we need to undo.
Yeah, I like that.
That we need to take care of the damage that's been done over the years.
Or it's irrevocable, and so let's try to stop it before it gets worse.
Yep.
It's
just wrong. So let's go to polling question number 8.
There is no, anything you can do to help open up the glands, anything you can do to slow down the progression of, that kind of thickening inspissation. We didn't mention, do you do lid scrubs still? Do you still recommend surfactants and using lid scrubs?
Yeah.
See, I think all of, lid scrubs, moist heat mask, I think these are things to remind patients that this is a chronic condition, that, we're basically, snow blowing in a snowstorm. I can't make you stop doing the things you want to do, but let's try to manage that. So I'm oftentimes trying to talk to them about little things we can do. And I know it's easy for us as clinicians to want to say things like, well, just grab a washcloth, and have them use a device and sell it in your practice. Yeah. Have it say, look, we have it available here. If you want to get it, if not, go online, do something else.
And that adherence is so important.
Yeah,
when
totally.
we're talking, and the only way to get that is to let them know it's a chronic condition. That's why I always say it's a marathon, not a sprint. We're going to be working at this. You spent a lot of time getting here, and now we're gonna undo some of the work that you have.
I also think too, when you talk about like lid scrubs, it's like, look, you had mentioned before, we have bacteria that lives on and around the lids. We have viruses, we have other little organisms. What this can do is try to kind of like maybe manage that a little bit, which is why I have such a hard time when doctors are still using things like baby shampoo. And you know who you are, okay?